Hi, this is Allison Rovat here again to present for you Lesson 3 in the series of 4 learning modules prepared for the Department of Developmental Services, specifically with you in mind. This lesson is going to focus on the experience of trauma amongst persons with developmental disabilities. I'm going to leave the presentation full screen for this one again. You'll see me return to the screen for Lesson 4 because I want to make sure to be able to show you all of the information, all of the different statistics related to the incidence of trauma amongst persons with developmental disabilities. This presentation will be approximately 20 minutes in length. Now I know the previous two have run a little long, so we'll say 20 to 25 minutes to be safe. I'm so glad that you're joining me again to learn about trauma and trauma-informed care. The learning goals for Lesson 3 are, broadly speaking, what do we know about the experience of trauma amongst persons with developmental disabilities? We're going to look at that question by examining a few different things: the prevalence, the lack of awareness and understanding, the impact of trauma, and the implications for interaction and treatment. Once again, before we begin, I just want to remind you that anytime we're talking about trauma, there's a possibility that our own experiences of trauma and our own symptoms of trauma might be triggered. I'm really going to encourage you during this presentation to take good care of yourself, to make sure you're using those good grounding skills, taking a few deep breaths, making sure you're comfy in your chair, getting up, stretching, moving around if at any time you feel upset or triggered by the information presented. Your self-care during these lessons is really important because your self-care will allow you to be present and to really learn the information that's contained in this lesson. It likely won't come as a surprise to many of you who work in the field that when we ask the question, how common is trauma amongst persons with developmental disabilities, the answer is quite common. In fact, individuals with disabilities are over 4 times as likely to be victims of a crime as the non-disabled population, and of course, persons with developmental disabilities are just as likely as the non-disabled population to experience other kinds of traumatic events. In fact, there's good reason to believe that when it comes to traumatic events such as natural and man-made disasters, the impact on persons with developmental disabilities may be even more profound, considering that factors related to evacuation, relocation, rebuilding, seeking protection, etc., may be experienced as even more traumatic. I want to say that the figures I'm going to present here have been drawn from a number of sources, and I've cited them in each case after the quotation. Please note, depending on the research study, the populations are defined differently. So in some cases, persons with disabilities are not delineated by type of disability, and in other cases, the groups are identified more specifically. I've tried to quote the studies here as exactly as possible so as to not add my own interpretations to the data, so you'll note that the language may not be consistent from one finding to the next. My motivation here was to include as many studies as I could find, and you will see there are certainly a lot of studies here, but of course there's so much more work to be done to really understand these impacts of different kinds of trauma on people with disabilities and their families and caregivers. So 64% of children who are maltreated and neglected had some sort of disability, according to this study in 1998. These disabilities range from behavior disorders, speech and language disorders, learning disabilities, developmental disabilities, and the most common type of maltreatment in this study was some form of neglect. The rates of sexual abuse are significantly higher in individuals with disabilities. The estimates range widely, but are up to 10 times more likely than those without a disability. That's a huge range, and one of the reasons it's so big is because we're really not sure that we have very good data about this, because we expect that sexual abuse, neglect, and other types of abuse are really underreported, really in all populations, but specifically in the population that we're talking about today. It's estimated that only 1 of 30 cases of sexual abuse or assault of persons with developmental disabilities is reported, as opposed to 1 in 5 in the general population. That is such a significant number because we know that these crimes are vastly underreported for everyone in society, and especially for those with developmental disabilities, for really a variety of systemic and social factors. When abuse is reported, there's a much lower likelihood that the accusations will be investigated and that the charges will be pressed when the victim has a disability. What we know by looking at the data on those crimes that are reported is that immediate family members perpetrate the majority of neglect, physical abuse, and emotional abuse. And outside of the family perpetrators, which can sometimes be other caregivers or workers in different kinds of programs, typically account for the majority of sexual abuse. Sexual abuse is 4 times as common in institutional settings as in the community at large. And one of the things that's really important to recognize is that 99% of those who commit abuse are well known to the child, to the child's care providers. And this is an old study, but this information has persisted to be true. And so we're talking here about children, but that same data is replicated in the adult population. What we know about sexual assault and sexual abuse in general is that it's most likely to be perpetrated by somebody that's known to the victim, somebody who has the trust of the victim, and oftentimes their family. And when we put all this data together, what this really highlights is that individuals with developmental disabilities are more likely to experience traumatic events, especially when we're talking about interpersonal trauma and violence, which really, again, underscores the need for all of those who work with individuals with developmental disabilities and their families and caregivers to have an understanding of the impacts of trauma and what that looks like. People with disabilities are at least 3 to 4 times more likely to experience abuse than those without a disability, and children with intellectual and developmental disabilities report overall more negative life events. So more loss, more life-threatening illnesses, medical events, more transitions, moving from one location to another, more injuries. And a lot of times what happens, and this is why this is such an important and devastating topic, is that when symptoms of trauma are seen in persons with developmental disabilities, they're much more likely to be labeled as problematic behaviors, destructive behaviors, or simply a symptom related to their disability, instead of a very, very normative and in many cases adaptive trauma response. And what we see time and time again is that trauma symptoms are consistently misattributed to the disability. One of the things that you'll find if you start investigating this topic is that there are a growing number of resources online dedicated to looking at the experience of trauma for persons with developmental disabilities. But if you start trying to find books on the subject, you'll find very few, which really shows that this is still an emerging topic, and it's much slower to gain traction than trauma has been in the general population. And yet, it's significant. The rates of trauma experienced in this population are incredibly high. The symptoms and the effects on individuals and families who are dealing with trauma are really noteworthy and really worthy of our attention, especially if we want to really work from a trauma-informed perspective. The truth is that there's a little bit of what I'm going to call an infinity loop between developmental disabilities and trauma when we look at the fact that abuse and neglect have profound influences on brain development. In the last lesson, we looked at those images of the brain, and we looked at a side-by-side comparison of a child's brain that had experienced neglect and one that hadn't. And what we saw is that the brain that had experienced neglect was much smaller. The more prolonged the neglect that the child experiences, the more significant the abuse, the more likely it is that there will be significant and permanent brain damage, and in a lot of cases, a lack of growth in the brain overall or in specific parts of the brain. When I use the term infinity loop, what I mean is that not only are people with intellectual and developmental disabilities more likely to be exposed to trauma in their lifespan, but early exposure to trauma makes it more likely that a developmental delay will occur, or that the developmental delay or the developmental impact will be more profound. And so there's that loop of people with intellectual and developmental disabilities being more likely to be exposed to trauma, and knowing that exposure to trauma makes intellectual and developmental disabilities more likely or more profound. When we look at providing support to individuals with developmental disabilities who've experienced trauma, one of the things that's important to recognize is that oftentimes there are certain impacts of their disability that put them at a higher risk for being re-traumatized or re-victimized. So, for example, cognitive disability can impact the ability to predict high-risk situations or to understand what is happening in abusive situations. A lot of times when I've worked with individuals with developmental disabilities who've survived an interpersonal trauma, this is something that we spend extensive time talking about and really practicing for, because this ability to have a sense that something dangerous is happening or that something is uncomfortable and in any way abusive is really important to try and develop in especially people who have any sort of cognitive disability. How we predict and, when a situation is safe and when a situation is dangerous, especially when we're thinking about working with individuals who might not have full verbal abilities, we have to think about providing access to ways to communicate what is a dangerous situation and ways to help people get in touch with that intuition that might be underdeveloped to help them identify an unsafe situation. There are also so many barriers to reporting these incidents, unfortunately, and it's something that I think there is a lot of advocacy for, especially in the field of developmental disabilities, and I hope that there continues to be more attention, awareness, and training committed to this issue in all aspects of the law enforcement and criminal justice process. Sometimes there are simply barriers to accessing police and, in law enforcement, barriers to transportation, mobility, a restricted ability to communicate, and a lack of appropriate access to somebody who can facilitate communication is a really common barrier. Also, there's the unfortunate stigma that individuals with developmental disabilities face in many corners of life, where they might not be perceived as being a credible reporter of what happened. The other thing that we see a lot of times is that individuals with developmental disabilities have in some way been socialized to be compliant to authority figures or to trust authority figures. And so often when we're looking at trauma, and especially interpersonal trauma, we're also looking at a really significant power differential. In a study in 2004, 44% of survivors of interpersonal abuse or trauma had a relationship with their abuser that was in some way related to their disability. Also, when we think about individuals with disabilities, especially who are living in a residential setting and who might be eager to seek out some sort of affection or attention, that can increase the vulnerability by putting them in a situation where there is a greater possibility of manipulation. Additionally, and this will not come as news to any of you, for a long time, there was just an inadequate amount of sex education around human sexuality, physical boundaries, setting limits for persons with developmental disabilities. And so that leaves a lot of people less than equipped to identify when something's happening with their body that just doesn't feel safe. I said earlier that the topic of trauma as being experienced by persons with developmental disabilities has been slow to get attention. And I think one of the reasons for that is that there's a lot of persistent myths surrounding trauma and developmental disabilities. One of the myths is a blanket belief that people with disabilities don't have the same response, or I think some people believe that they don't have any response to trauma as people in the general population. There's also a very persistent belief, and this is coming from me as a counselor, I can definitely attest that this belief is out there, that people with disabilities cannot benefit from therapy or counseling, including trauma-based treatments, and that working with individuals with disabilities requires extensive specialized training. There's also a myth that individuals with developmental disabilities will forget or get over the trauma, that somehow, I'm really not sure how people imagine this happens, but that the disability will somehow erase away the trauma, and what we see is that's simply not the case. As I said before, oftentimes challenging behaviors or any kind of behavior that seems in any way aggressive or resistant is explained away by the disability instead of investigating whether it might be a protective response related to a trauma. There's also the myth that obviously the Department of Developmental Services is working hard to change, but that behavior modification is the only option for intervention. And then there's sort of a widespread myth in trauma in general that the only way for people to heal from trauma is to tell in detail the story of their trauma. And that if someone doesn't have access to the language or the cognitions to do that, that there will be no sense in supporting them through a trauma recovery process. But of course, these are just myths, and the facts are that people with disabilities suffer from the same challenges and difficulties in life, and that certainly includes having a response to traumatic experiences. The reality is that many different approaches have been found to be effective in treating individuals with developmental disabilities. And in fact, when we look at the kinds of things that have been found to be really healing when it comes to trauma, a lot of those things are expressive and creative kinds of therapies that are rooted not in psychotherapy or talk therapy, but in body techniques and breathing techniques, in using our senses in different ways, in being creative and artistic, in using movement. And there's a lot of room for adapting those techniques to work with people with all sorts of abilities. What has been found is that although it can take longer for people with disabilities to make changes surrounding their trauma, once those changes occur, they endure and they can be built upon. If we rely on the myth that says that behavioral change and behavior modifications are the only way, we miss the whole level of the trauma. And so we want to think about looking at every behavior as communicating something to us. And I know that that's part of the work that all of you do already in working with individuals with disabilities and thinking about how you interact with them in a person-centered way. That way, we're looking at behaviors as a communication tool. And if you think of it that way, we can see some of the symptoms of trauma embedded in behaviors. What the data shows is that people with developmental disabilities are less likely to spontaneously recover from trauma without some sort of support and intervention. So that's all the more reason why we get really creative and think about the ways that we can reach the trauma experiences of these individuals. Just in general, the idea that people need to be able to tell their story in detail in order to heal from trauma is something that we have seen debunked in a lot of different trauma recovery models that are out there. A lot of times people don't have access to the exact retelling of their trauma. And that's because of what we saw yesterday or previously when we looked at the images of the brain. We know that because a lot of the information that happens during trauma is stored in the nonverbal parts of the brain, a lot of times people don't have access to that story. And if they do have access to the story, they might not have access to the kind of communication that would be needed to retell the story. And that's absolutely fine, because what we see is that trauma is stored in the brain in different parts of the brain, and we can access the brain and help heal the brain in ways that don't have anything to do with telling the details of the worst thing that happened in our lives. Those of you who are watching this who work in the field are well aware of the challenges that I'm about to review. These are some of the things that we can look at as challenges that we can overcome, that we can approach from a trauma-informed perspective, which we're going to talk more about in the next lesson. We know that very often for individuals with developmental disabilities, their care is in some way fragmented, that there may be a lack of consistent information carried through from provider to provider. And so a lot of times information about a person's trauma doesn't necessarily get carried forward. It might be the case then that the next provider that comes in to work with that person doesn't have that information about their trauma history, which would prevent them from being able to maybe recognize how some of their behaviors and responses could be rooted in some sort of traumatic experience. One of the things that's really lacking in general, and certainly specifically to persons with developmental disabilities, is that there's not a lot of peer-to-peer support networks out there that are related to trauma and providing support to individuals and families surrounding the experience of trauma. The other thing is that the risk of re-traumatization, of reactivating something traumatic that's happened, is really high, especially when we think about there being disruptions in placements. A lot of times when people are living in residences where they can't have a lot of control over the sounds or other sensory experiences in the house, there's a risk that their trauma will be re-triggered. Something that can often reactivate trauma is a disruption in living situation. And we know that for a lot of people that ends up being a fairly regular part of their care, that they might be shifted from one placement, program, or caregiver to another. And that can really be re-traumatizing. And while there's little chance that we can create a world where these sorts of transitions never occur, from a trauma-informed perspective, what we can do is make efforts to prepare people for these transitions, and then to really process the transition after the fact as best as we possibly can, and look for any symptoms that shift in or that transition was traumatic to them or reactivated some sort of past trauma. Oftentimes providers, and some of you might be nodding your head right now, feel insufficiently prepared to deal with trauma. And hopefully these learning modules are part of a first step for all of you in starting to feel more comfortable in recognizing the impact of trauma. The fear of working with individuals with developmental disabilities often leaves us with a lack of well-trained providers. It's not easy to find, number one, counselors who specialize in trauma, but number two, counselors who specialize in trauma and are willing and able to work with individuals with disabilities. But that's really what we need to aspire towards. A lot of times, the evidence-based trauma interventions exclude any discussions of persons with developmental disabilities. And a lot of times, as I mentioned, the default is to focus on behavioral issues, which really misses the identification of or the attention to the traumatic experiences that have happened. So sometimes you'll hear this referred to as diagnostic overshadowing, which is really the idea that we focus on one diagnosis and look to that as explaining everything that's going on in a person's life, instead of looking beyond just the diagnosis of a specific disability to see that there might be other factors, especially trauma, at play. And so given all these things that we just discussed related to fragmented care, the changes that go on in any person's life, the risk of re-traumatization, the lack of providers that feel equipped to deal with trauma, and this concept of diagnostic overshadowing, it can really be difficult to assess the impact of trauma on the development or the life of a person with a developmental disability. And so it's something that as we increase our understanding of trauma and our awareness, and as we look for ways to strengthen communication between care providers, this is something that hopefully we'll be able to see happening more and more, that we can identify these trauma responses with more accuracy. In the next lesson, we're going to talk more about a trauma-informed lens and trauma-informed care. But just while we're having this discussion right now, I want to give a few guidelines for you to think about. The first one, and the most important one, especially given what we just discussed on the previous slide, is just to not attribute normative trauma responses to a person's disability. To not assume that a behavior is simply communicating that that person has a disability, but that a lot of times behaviors and actions are communicating something different or new, and very likely could be related to a trauma that they've experienced. I also want to point out that a lot of times a person with a developmental disability would have the same kind of symptoms following trauma that anyone would, including sleep disturbances, increased startle responses, a numbing or detachment, being emotionally constricted in some way. That might look like not smiling or laughing or engaging in the way that a person normally would. A disrupted sense of safety, which might look like suddenly not trusting people, places, objects, experiences that they once did. What's most important is that we recognize that trauma responses generally represent a change from a person's typical level of functioning. And that's why continuity of care and really, really excellent record keeping are so important. If we document exactly who that person is day to day, then we're able to help other staff and caregivers that work with them to recognize when something changes. If we're not communicating from one staff member to the next, it's easy for these symptoms to get overlooked. And whenever we can identify the impacts of trauma earlier on, the chances for healing and recovery are much brighter. It's also important, and we'll talk more about this when we talk about trauma-informed lens and trauma-informed care, that we recognize that a lot of times past instances of abuse and traumatic events can be triggered by things that happen in the present. And these can be very everyday things that we might not even think about as being potentially triggering or re-traumatizing. Any of these things listed on the screen can be very triggering because they can be evocative of past experiences of abuse. And so when we think about the kinds of things that happen on a daily basis and we look at those interactions through a trauma-informed lens, what we can realize is that simple everyday interactions have the potential to be very traumatizing and very activating for someone who has experienced trauma and who is experiencing some significant traumatic symptoms. And so, for example, if we notice that somebody is suddenly responding in a different way to jokes and sarcasm, that could help us understand that something has potentially happened to change the way that person is interpreting and reacting to that kind of humor. So I'm just tiptoeing over my time mark once again, but there's just so much to say on this topic. So if you'll bear with me for just one slide, where I want to end, because the next module is going to talk about trauma-informed perspectives, using a trauma-informed lens, and trauma-informed care, is that what we have to think about from a trauma-informed perspective is that we start all of our interactions, all of our observations, and all of our interventions by first considering the impact of trauma. In some ways, we flip the paradigm, and instead of starting with targeting a behavior, we start by thinking about trauma and the impact of trauma. And then from there, we think about how that trauma might have impacted a person's emotional responses. And then lastly, we think about how the experience of trauma and related emotions are being communicated behaviorally. And so if we start simply at the behavioral level, we miss the possibility of exploring this trauma as an underlying concern. And the truth is, lots of times we are going to work with people who have experienced trauma, and we're never going to know for sure that that's the case. We might never have a thorough history. We might never be able to take a thorough trauma account from the individual, whether that's a result of their communication abilities or simply them not having access to those memories. And so the thing about trauma-informed approaches is that trauma-informed approaches really benefit everyone because they consider the possibility that the behaviors and the dispositions that are being exhibited have some sort of underlying cause or concern. All right, so what we're going to do here is I'm going to pause, and I'm going to join you again shortly for Learning Module 4, where we're going to talk much more about this idea of trauma-informed care and what it means to develop a trauma-informed lens. Thank you so much for being with me for this lesson and for being patient as I run 2 minutes over the clock, and I'll look forward to joining you for the next lesson.